So a very good afternoon to all of you. Again, thank you so much, the organizers. I think a very tough time to stay here. Hopefully, I will not bore you much. I will keep it as short as possible. Now, this is very important. Sir has already told that most of my chronic hepatitis B patient, the mortalities and morbidities because of this thing. There's a decomposition of cirrhosis, and second is the most important thing is this hepatocellular carcinoma. Now, when I attended the class last year, this master's class in 1.0, then as a physician, I was not so much aware of this, when to screen such type of patient and what is the importance of this. Now, after when I attended and went, then I saw a lot of patient. I focused myself that I must screen such patient because I can do benefit for the patient. And frankly speaking, not much, but one of my patient really saved from this hepatocellular carcinoma because I was able to diagnose it earlier. So me as a physician, not and the patient who are not hepatologists, who are not gastroenterologists, we should know when to refer this patient, when to take action in such type of patient. So that is importance, in fact. So my objectives will be, I will let you through the little bit about introduction, is how to screen, and are there any evidences to support hepatocellular carcinoma screening, who to screen and how to screen. These are my objectives of the study of this class. So introduction, this chronic hepatitis B, the risk increases 15 to 20 fold in infected versus uninfected individuals. This primary liver cancer is the seventh most common type of cancer globally and fourth leading cause of this annual cancer related death globally. Now, males are comparatively higher risk for developing this carcinoma as respect to women, and 80 to 90% of people with hepatitis B are associated with HCC who has already underwent cirrhosis and been diagnosed. But we should not follow that HCC may occur even without cirrhosis. Common in cirrhosis, but HCC can occur even without cirrhosis. Now, the challenge with us is that this HCC may be asymptomatic until it presents clinically. And that is where our rule comes to screen the patient, such type of patients. Prognosis too is affected by many things like size of the tumor, number of the tumors which are located, and if diagnosed early, we can offer these type of patient a curative therapy as such. Now, this has been discussed in the previous talk that what the most important thing which is leading to hepatocellular carcinoma is the chronic inflammation, and this hepatitis B virus, as we have discussed, that it integrates in the host genome and which causes the genetic instability, ultimately leading to hepatocellular carcinoma. So there are some risk factors in hepatitis B patient who are more prone for hepatocellular carcinoma. There are host factor, viral disease, viral factors, and environmental factors. So viral factors are pretty important. The presence of cirrhosis, most important. High viral DNA load, HBE positive status, genotype C, and longer the duration, the more is the risk of developing hepatocellular carcinoma. And if there is concurrent infection, the risk again increases. The patient who are suffering from who are alcoholic and who are suffering from this metabolic syndrome type of things, then this risk increases approximately 10 times more in such type of patient who is hepatocellular carcinoma, who's this HBV positive patients. So there are some protective factors also. If we immunize, if the patient are immune because of vaccination, and we are giving this antivirus, then probably this patient, the development of this hepatocellular carcinoma delays. Now we see that if this hepatocellular carcinoma is localized, we see that this is the basically prognosis of the hepatocellular carcinoma. If it is localized, it is good prognosis. As there is distant met or regional met, depending on the metastasis, the prognosis worsens. Now, are there any evidences? Yes, there are evidences, pretty evidences that this hepatocellular carcinoma is associated with a significant improvement in the early tumor detection, and we can offer the curative therapy in such type of patient, and ultimately we can improve the survival of this patient. So there was a study done in it is little bit of old study, but this was a prototype study actually. That is why I'm telling. It was in this China. China is always a way ahead. In fact, one step ahead from us. So this was they enrolled about 20,000 patient, approximately 20,000 patient, and but they screened the patient with alpha fetoprotein and ultrasound every 6 monthly. What they observed was they were able to diagnose on the stage 1 about 60% of the patients, and stage 2 when they were not in the control group. So that sense, the screening helped in the patient. Not only this, we can also see there was mortality benefit when we was offering the screening in such type of patients. So there are always some hindrances in the screening of. There may be some factors like the patient may be undiagnosed for chronic hepatitis B infections. There may be the hepatofibrosis stage may be unknown, And there may be lack of clinician awareness in the screening, and obviously cost is always the one of the factors in India because we are living in a resource limited settings. Now, who are the patient to screen? This becomes very important. All the patients who are cirrhotics, they must be screened except for class C, because we cannot do much to insist in this type of patient. Males more than 40 years of age, females more than 50 years of age. If there is family history of hepatocellular carcinoma, and page B score. This is scoring system based on the age, sex, and platelet count. If these any of this is present, we are supposed to screen the patient every 6 monthly. The second is, how are we going to screen? There are two modalities. One is imaging and other one is markers. So one is this in imaging, we have ultrasound, we have CT, we have MR. And biomarkers, we have alpha fetoprotein is the most commonly things done. Others, just for sake of completion, we are not using because most of the guidelines, any of the guidelines do not recommend this. So if you talk about imaging, now this ultrasound, as we know, the sensitivity is 40 to 80%. Now this depends on the expertise who is doing ultrasound. But advantage is that it is safely available. It is safety, availability, and cost effectiveness. But there are limitations because of lack of standardization, then examiner dependence, and limited sensitivity, particularly if the patient is obese and there is fatty infiltration of liver. So can we offer CT or MRI in such type of patient? Probably no, because this is not actually cost effective, and we should not subject this patient to potential harm for radiations. So, but yes, they have role when even if the size of the tumor is more than 1 centimeter on USG, then we can subject this patient to the CT scan. Actually, this is a type of diagnostic, not of this thing for screening purposes. And it can obviously it can false positive test. They can trigger the further workup and the anxiety of the patient and attendants too. That is why it is not recommended as such. MRI again the same things as the CT. Then I guess it has always we need more of infrastructure, and we have lot of cost effectiveness. There is no cost effectiveness with the MRI screening. So screening with MRI and CT is not done. In fact, this is for the diagnostic purpose. If we are suspicious in the ultrasound, then we should subject this patient to the CT or MRI. This is actually for both are for the diagnosis, not for screening. And what is what we see in the CT scan? Actually, what there is something which is known as arterial phase hyper enhancement, and port venous and delayed phase is hypo enhancement. So first one is a non-contrast CT. Second, there is enhancement of this tumor, because the aorta is hyper intense. We can see there is intense, and in the delayed phase, they again become hypoechoic. So after this imaging, we coming on to this biomarker part now. This alpha fetoprotein is recommended in some of the guidelines, but not standalone. The reason being, because advantage we see it as easily available, less expensive, and easy to perform. But the problem is that sensitivity is only 60%. There is lack of uniform secretion by this alpha fetoprotein by hepatocellular tumors less than 3 centimeters. And there is evidence that there is false positive because of the tumors in the ectodermal origin. There may be non-semen advanced germ cell tumors, pregnancies, and regenerated livers in the setting of acute liver failure. So usually it is not recommended standalone, but in the with ultrasound we can this can give the add-on add-on sensitivity in the patients. So simply for the sake of completion, these are the other markers which, but none of guidelines recommend this. There are various, some predictors. There are some scoring systems, but at present, none of the guidelines recommend these endorse these type of things. So there is debate over the benefit of this AFP, adding AFP to the ultrasound. This be it European, American, or this Asian specific guidelines, it is not recommended in European, but it should not be used as standalone, but with clubbing with ultrasound, it increases little bit of sensitivity, so it should be used. So lastly, this hepatocellular carcinoma, as we know, it is a leading cause of cancer and related death worldwide, and this HBV is one of the very important causes in our country, and overall 5-year survival of hepatitis C is approximately 20%. So that is important. We should screen such type of patient. And primary goal of this hepatocellular screening is to detect the disease in the early stage, and so that we can offer this curative therapy for such type of patient. The recommended thing for this hepatocellular screening is hepatic ultrasound every 6 monthly with serum alpha fetoprotein. Thank you.